We move on to Siemens, and Dr. Rajgopalan will provide us an update from Siemens.
Hi, my name is Dr. Rajgopalan. I'm the Chief Medical Information Officer and the Global Head of Clinical Decision Support. I'm a primary care physician, so I'm more interested in, because most of the patients go through the primary care physicians because they are the gatekeepers, right? So we talked a lot about difficulty in identifying cases in Nash and NAFLD. So when they go through the primary care physicians, and we need to support them in terms of identifying them so that they can catch them early and then refer them to a hepatologist or specialist. So that's the whole idea. So my passion has always been using AI and machine learning to be able to help clinicians at the point of care, like in the bedside or in the clinic, to be able to identify diseases very early. So if you look at the medical record, the lab test is the most objective form of data that is available, and the CDC has said that 70% of the diagnosis is made using lab tests. And yesterday we saw the compartmentalization of medicine, right? Because every specialist are looking at their particular organ system, but the body doesn't work like that. It's a pretty integrated machinery, right? So at least from the diagnostic perspective, we think that we need to be comprehensive and integrated in terms of diagnosis. So one of the things that I'm more interested is that looking at the most objective data, which is the lab test. As you know, blood circulates through the body about 100,000 times, perfuses all the organs in the body from head to foot, and it has got a lot of information. So can we use machine learning or artificial intelligence to be able to uncover that, right? So most of the physicians, as you know, a number of studies have shown that 20% of the tests are irrelevant when they order it, and 40% of the irrelevant tests are not ordered. So if you add up 60% of the tests are not even there. So most of the clinicians in primary care, when we get about 30, 40 test results, we just scan through them and say, is it any flags, right? Whether it's outside the reference range or not. Even the reference range, as you know, is based on 100 self-declared volunteers and one particular, demographics. So if a patient has a whole bunch of high normal or a low normal, does that mean that the patient is normal, right? Because it'll completely miss the radar and fall through the crack. So the whole idea of machine learning is that it is able to look at the entire spectrum of lab test results, and it'll be able to identify and give insight into what may be going on with that patient. So what we did during the COVID time is that, as you know, a lot of patients were turned away because of their lack of space in the ICU. So if only we could have a model that will identify which patient is going to deteriorate, right? Going to end up in the, respiratory failure, multi-organ failure, then we'll be able to triage them, whether saying that, okay, this patient probably may needing a ICU bed, so we shouldn't turn them away. Another patient maybe seems to be stable, and this patient may be okay if you can treat them outpatient. So that is, we got a lot of experience actually building that because the model performed very well. So we used that model after COVID to be able to identify potential diseases which are silent killers, right? Like chronic kidney disease we talked about, especially Nash, NAFLD, cirrhosis, and also looking at cancer models. So I just today want to share our work on basically the liver model that we built. And one of the important things when we go, and I've been a practicing physician, so I know that any kind of model, any kind of application that you build has to be totally integrated with the system. So no physician is going to go to a different system, different workstation to do this. So it has to be integrated. So one of the advantages Siemens has is that we have footprint in most of the EMR system because our instruments are connected with the EHR. So we will be able to provide our insight about the lab test results on the same context where the physicians are reviewing the lab test results. So it makes perfect sense for us to be able to do that there because it's key. The picture shows that we did a total integration at La Paz University Hospital, and the feedback that we got it's any type of AI-based models or any of these applications will be only useful if it is totally integrated at the point of care. So that is exactly what we are talking about. I don't want to go through this particular slide. You probably have seen this multiple times. The whole idea is that can we detect, liver disease very early? Can we screen the population for liver disease, especially supporting the primary care physicians, ED physicians, so that they can catch them and then able to refer them? So, as a hepatologist, you are familiar with a lot of scores. Like FIB-4 score is one of the top one that's being used, and there are other scores as well. And FIB-4 usually takes care of, it's an equation based on 3 markers, right? So if one of the markers is missing, then we won't be able to calculate the FIB-4 score. And yesterday we heard that a lot of patients with liver disease has diabetes. And if you go to a diabetologist, they're going to look at HbA1c, fasting glucose, and then they are not going to look at the liver. The same is the case with the cardiologist. They're going to look at the cardiac markers. But most of the metabolic syndrome affects pretty much all this organ system. So is there any way that the artificial intelligence will be able to take whatever results that is available and able to predict liver disease? So that is the whole idea. And we had some very, very encouraging results. This is just one screenshot of one scenario where there is a healthy liver scenario. So as you can see here, the FIB-4 score is pretty low. So if you can think about it, the numerator consists of AST. So if there is a high AST, and then it's a low platelet count and ALT, obviously the FIB-4 score is going to be really high. So does that mean that the patient has a problem? Same is the case, exactly opposite. You'll have a very low FIB-4 score. Does that mean that the patient is normal? So this particular case, as you can see here, the FIB score is low, and also we predicted like 0.69, which is, so the score actually goes through from 0 to 5. And 0 being normal and 5 being, liver failure, and in between, like, early fibrosis, late fibrosis, cirrhosis, and things like that. So there is another screenshot that I'll go through here. And in this one again, yes, this is a fibrotic cirrhotic liver scenario where the FIB-4 score is still 0.68, which is kind of lower. But what happened was the patient has a very high glucose and HbA1c, and it was able to predict, a severe form of fibrosis and cirrhosis. And actually what we give, most of this blood markers or any kind of model is based on the pretest probability or the prevalence. So here we actually give the pretest probability as well as how many patients with a similar blood profile. It's all basic routine blood test with the age and gender. How many of them have ended up with this advanced liver disease? So we kind of give you that score so that you can make a decision whether you want to order a ELF test or you want to do a fibroscan or things like that. So we able to give that number of patients with a similar profile, what exactly they ended up with, so that the patients that is sitting in front of you, you can decide what exactly you want to do. That is the whole idea. So it kind of takes into account all types of different markers and come up with a probable scenario. So in this case, 0 to 1 is, as I said, healthy liver. 1 to 2 is NAFLD. 2 to 3 is NAFLD with early fibrosis. 3 to 4 is NASH. And then 5 and above is like hepatic failure. I have just one more slide. I think. So you get the idea is that how we can use normal routine blood test to be able to identify diseases early and to be able to alert the primary care physicians so that they can immediately follow up with that patient, so refer to a specialist to be able to identify and follow up with that. So that is the whole idea, and we are really excited about our initial findings using this. And if it is integrated with the EMR, it'll be really helpful for those primary care physicians and ED physicians to be able to identify this so that we can catch them early and give appropriate, build additional, evidence factors like, a special test or fibroscan or MRI, PDFF, and then avoid biopsy if at all possible, and only do biopsy for patients who really need it, as we all know that it has got its own risks involved. So I'll stop here and, take any questions. Thank you.
Thank you. And then